Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island and entire tri-state community. Tonight, we're going to be talking about pediatrics. And there's a lot of topics about pediatrics, and we have a wonderful pediatrician, someone who actually was my children's pediatrician, someone who I respect and is a wonderful physician, Dr. Mendez with us. Dr. Mendez is the Chief of Pediatric Ambulatory Care at Richmond University Medical Center. She is trained both as an internal medicine physician, which is a doctor taking care of people who are adults, and as a pediatrician. So she really takes care of everyone from the very beginning to very end of life. And she really has been wonderful, and it's been a wonderful colleague of mine. It's been a pleasure to work with you. So we're going to talk about pediatrics a little bit, and especially during this COVID era. But what I'm going to first get to is what is a pediatrician? How do you get to be one?
So a pediatrician is someone who takes care of kids, of people 21 years or younger. I actually went to college and went to medical school for 4 years, then applied to a residency program. When I made that decision, I wanted to take care of adults and children. So I went through a medicine and pediatrics 4-year program and took 2 boards and became board certified in both, and practiced both for 15 years. And when I was asked to become the chief of ambulatory pediatrics, I took a lot of my time. So I've been practicing mainly pediatrics for the last 5 to 6 years. And that's how I became a pediatrician.
How marvelous. So pediatrics, you know, as a neurologist, I wear a white coat in my office. And sometimes families bring their children in, not to see me usually because I'm an adult neurologist, but just to take care of themselves, and they have no one to watch them, so they come in. And when I walk in with my white coat, there's usually a shriek or something like that. I think there are a lot of people who are afraid of going to the dentist. We've had dentists on the show.
Including myself. A
lot of people, I didn't know that. A lot of people are afraid of going to, a lot of children are afraid of going to the pediatrician. My children still talk about a stick and they know what happened with it. So how does a pediatrician work that and be able to take care of a patient who really can't sometimes talk or give you that much information and is afraid of coming to see you?
Well, I never wear a white coat. That's my philosophy. You have different pediatricians with different philosophies. You know, you always have to, as a pediatrician, remember that the patient is the child. So I always come into the room, speak to the parent, get the story, but then when I'm going to see the child, I get at their eye level, okay? You know, somehow, because you want to be able to talk at their level of what's going on, depending on their age. Even with newborns, you know, you'll look at them, you know, this is the patient, right? And it's remembering that the parent is an advocate, but the patient is the child. And everyone has their own technique. Medicine has an art to it. And my technique is not to wear a white coat, to always remember that the patient is a child. Listen to the parents, they're their biggest advocate, but always remembering that the patient is a child, and, you know, using any tool to be able to communicate with them, to get to know what's going on from their perspective.
So we talked a little bit before you came on the air with me about different age groups. And you know, sometimes in adult medicine, we talk about younger patients, we talk about senior citizens, we talk about older patients, older patients, trying to differentiate them into different categories in order to try to figure out what might be wrong with them. It's different for me if someone comes in and has weakness, say, on one side of their body and is 80 years old, than if they're 20 years old.
Very different.
You know, 20-year-old patients worry about things like multiple sclerosis. And again, there is overlap. People who are 70 or 80 were worried more about having a stroke. So there's a lot of differences in what we see. So tell us about the different ages in pediatrics that you see.
The first thing to remember is that kids are not little adults. And even within that 0 to 21, according to the age group, there's a lot of differences in how you practice and what can be causing symptoms. So we look at pediatrics as infancy, which is less than 12 months, from birth to 12 months, early childhood until 5 years, late childhood, and then preteens from 11 to 13, and teenage years from 13 to 18, and early adults from 19 to 21.
Tell us about the infants. Because infants, it's always interesting as someone who, you know, I've done pediatric neurology work, but just the idea that of a patient that really can't talk to you.
Yes.
Can't give you much information. And I think you told me how cautious you have to be with infants. So tell us a little bit about what we're watching for with infants. What for new moms and dads really they have to look at their child and sort of get an idea of and they know them, of course, and they're advocates better than any of us, but just the idea of what we have to look for in infants and what problems can be.
You have to remember that infants are still developing many parts, including their brain, their immune system. So any symptom in an infant will be more cautious than a kid, older kid or an adult. Because kids, can decompensate quickly. So whenever there are symptoms that you think need to be addressed, address them. That's number one. A parent is there with a child all the time. They know when something is not the routine. Pick up the phone, call your pediatrician. Every pediatrician appreciates that because we want to make sure that we don't miss anything. The second thing is we see kids a lot in the first year of life. We see them at 2 days, 2 weeks, 2 months, 4, 6, 9, 12, 15, 18, 24, and 30, and 36 months. So I encourage parents to make it to their pediatrician at those times because we are looking not only at a kid when they have something, but we want to prevent. And the way to prevent is to look at them as they come in. Weight and height for children is a sign of good health and development. When you come into your pediatrician and they get a weight and a height and a head circumference, those simple tools tells us a lot about their brain development, about their body development, and the only way a pediatrician is going to catch any abnormality is by you coming in for those well care visits.
Tell us about developmental delays. I mean, we've seen so much of an explosion of children on the autism spectrum, and the idea of kids who are having speech delays. Tell us what the pediatrician's role is with this.
So the pediatrician's role is to do surveillance at all times, at any visit. It could be a well-care visit, it could be a sick visit. To always be mindful that of knowing what a child should be doing at every age.
So tell us, what do you mean by that?
Meaning that if you are, for example, 2 weeks old, you're expected to do certain things at that age. The pediatrician knows that. And as you examine the patient, you look for those things. And you ask parents if they're doing those things. So that's key. The AAP, the American Academy of Pediatrics, has, with that in mind, has recommended not only looking in your exam, but doing actual evidence-based evaluations at specific ages. And pediatricians now do that at 9, 18, and 30 months for entire development, meaning communication, motor, fine motor, personal and social development at those stages. And we do screening for autism at 18 and 24 months of age.
So it's important for the pediatrician. And what if you do find, now how about this? If a child is slow, does it mean they have autism? Does it mean that if they have problems with some speech delay or if it takes a little longer? Tell us a little bit about that.
No, speech delay is actually very common, especially at an age where we have a lot of kids who are being born prematurely and that we're able to save with our wonderful technology in our in neonatal intensive care units. So that's one population, right, of which we see a lot because we're connected to a hospital that has an intensive care unit, a neonatal intensive care unit. That's, those we surveil more, we do evidence-based evaluations, and those kids immediately get referred to early intervention and for evaluation, especially for motor, which is the first thing we see. So that's a specific population. For kids who haven't gone through that, we do the surveillance. If we find an area that is not to par with their age, I always tell parents, no one's labeling a kid because parents are afraid we're going to label kids. It's not a labeling. It's really prevention. Because I'm not going to go tell the school system or anybody, that the kid is a little behind in one area of development. But what really we press for parents in our practice and we discuss with them is that when we do these evaluations and we recommend that the child should be evaluated for speech, motor, or fine motor, or anything else, it's really to get an expert with more tools that are more evidence-based than the ones I have to really determine if they need any help in reaching their developmental stage. And that's something that we do on an ongoing basis in our practice. We refer them, if there is a speech delay, for example, to early intervention and to our rehab department at Rumsey, which actually has developed a wonderful program for kids with developmental delay, where they can get speech, occupational therapy, physical therapy, And it's something that has grown a lot in the last 5 years, and that we have managed actually to give as a service to our community.
Super. And again, just the idea that children who do have some developmental delay, there's a lot of hope, a lot of treatments out there, and many of them do catch up.
Yes.
So that's so important that there's some surveillance and not just hiding from it.
Exactly.
So let's talk about COVID now. I mean, COVID-19 is a pandemic that's affected us for the last 2 years, almost 2 years. And how does that affect pediatrics? In the adult world, where I take care of mostly adult patients, a lot of patients didn't come to the office for a long time.
The same thing in peace.
tell us what happened to me, and how do you catch up with this? So say mom didn't bring the child in, all those dates that you mentioned, you know, 2 days, 2 weeks, 2 months, and should they feel guilty about it? Should they catch up? Should they? What should they do? Are you going to be upset with them?
No,
So tell us a little
no
bit.
one's going to be upset with them ever, even if they, you know, the idea is to really meet families where they're at, and to really be a resource for them. During the pandemic in 2020, what our practice went to telehealth like every other practice, but we made sure we kept doing the well care visits even with telehealth, because even though we couldn't examine the kids, we were able to go over development, and we were able to schedule times to come in kind of distance to get their vaccines. We actually managed to do that. Since New York City kind of like opened up in July, we also opened up to our patients in person. And even, you know, during the pandemic, if someone needed to be seen in person, we saw them always with following the precautions to avoid COVID being spread. And we continue now to be fully open. And parents are coming back. Kids are getting their vaccines. Kids are being evaluated. Kids are going to early intervention, to therapy. And basically things have kind of like, for us, gone back to normal in our practice.
As of our conversation today, when we're talking to each other, COVID is approved for children over the age of 12.
The vaccine, yes.
Vaccine,
yes.
COVID vaccine, I'm sorry. So tell us, what's your opinion about younger children getting the vaccine?
So, you know, as a pediatrician, what we've done always is vaccinate kids to avoid them from acquiring a disease that can make them very sick or kill them. And COVID is a disease just like that. Even though adults are affected more, some kids get affected, and one kid who gets very sick or dies from COVID is one kid too many.
Absolutely.
So just like with all other diseases of childhood that we have prevented and eradicated, for example, polio, right? Kids used to get paralyzed. I mean, there's some adults left, I think, who had polio.
I still see some
You still
patients
see of them, right? I don't know.
yes.
They're probably in their 60s or 70s
Who have
now.
very thin legs, who are very weak. We had a president, Franklin Delano Roosevelt, who had polio.
Exactly. So that doesn't happen anymore because we eradicated polio with vaccination. The same thing with something like smallpox, way before us. You know, a very dangerous disease, eradicated. So a lot of the decrease in infant mortality, meaning in kids less than 12 months, has happened in our society because of immunizations. If we didn't immunize our kids, we would be as high as in 1900, all right? So COVID is just another disease that can make our kids sick or can kill some of our kids, and we avoid that by vaccinating them. We're very hopeful that we will, you know, we've been vaccinating 12 and older in our practice, many of them every week. They've been doing fine. They're ready for school. When the FDA gives the go for the emergency use for kids 5 to 11, it's something that even parents are asking because they know that they want to protect their kids from getting sick or dying. So, you know, it will be just a natural thing for pediatricians to do that because that's what we do all our lives as pediatricians, is prevent disease with vaccination.
So are you seeing children with COVID? I mean, since the pandemic, have you been seeing younger children?
Yes. In 2020, as an outpatient setting, you know, the people that we really had to see, we saw. And, you know, newborns were people we really had to see. So the main people that I saw with COVID were mothers of kids and some newborns during 2020 that had COVID because they had, you know, and after, you know, in this year, after people started to get vaccinated, I rarely see now any mother or newborn with COVID, but we are seeing a little more than we did before. The same thing in the hospital, all right? Not as many as in 2020, but we still have had over the summer a few kids admitted to the intensive care unit in pediatrics for COVID, teenagers, and a few kids that that have been diagnosed with testing. So what we're following still, even though we're open completely, we do every night. We call every family that's coming in, and we do a kind of like screening for COVID. And if anyone has any symptoms or anything, we make sure they come at a time that they're not going to be with everybody else. Or if they have been diagnosed with COVID, we do telehealth until after the quarantine.
Let's talk about just routine, the flu, upper respiratory tract infections. I mean, clearly COVID has affected the way we look at someone who has a cold.
Yes.
So tell me and I want to really bring this back to our parents. Like if your child has a temperature and a cold, and they're under the age of 12 right now and couldn't have been vaccinated, what should they do?
They should definitely contact their pediatrician because there's different tools to fight a pandemic, right? Vaccine is one, but also precaution of not having people who have COVID with other people who don't have COVID, so it doesn't get spread is a big one, right? Because that will avoid mutations, new mutations. So it's our practice now that and families know that they before a kid had runny nose, no one cared. Now everyone's like, oh my God, this could be COVID, and they're right. So when they call us and they tell us, my kid has a runny nose, I want to know what's going on. We make sure that following precautions, we bring them in. We do testing for COVID with PPE. We check also other viruses, and when we get the results, we contact the family. And we luckily only had a few that were actually COVID in the whole summer. Most kids are getting other diseases like RSV, adenovirus. Oh my God, RSV. So let me tell you something. One of the things that happened with masking is that we didn't see anything except COVID for the entire March to the end of 2020. So we usually saw a bunch of people with the flu, a bunch of people with RSV, silent, okay? Also, they were not coming to the office, but really, we didn't see it at all, or even in our telehealth. So one of the things that has happened after we went back to kind of like more normal life is not all these diseases are coming back. So RSV is even off season. RSV is usually from October to April, and the whole summer I've been seeing RSV. Okay,
Really?
I probably saw a few last week. And there's other viruses like adenovirus, which is really, we've been seeing a lot. And yes, there's other viruses that are infecting kids that are usually like, upper respiratory viruses that exist, but they're coming all together. It's interesting to see that.
I think you were interesting that you told me before that because of COVID, because of the testing, so we test for COVID, but now there's also a test for other viruses that cause
so
it.
it's not something we did before, but it's something that we've made. It's not like there's a guideline to that. We've made part of our practice because parents want to know what's wrong, right? They always, and it's important for us to know what's wrong, especially when things are off season, right? To help us guide, especially with young children, right? Something, for example, like RSV. RSV can be really, for an older child, an adult, it's just a cold with a lot of cough, a lot of secretions. But for a small child, especially someone in the first 2 months of life, you want to know if it's RSV because they can get sicker at a specific time after an infection. So if you know what it is, you can give better advice to parents on how to follow the care. And if I've had in the last month a couple of kids before the age of 1 month that had RSV, and they came to see me, they were fine. We spoke about when the time that they can get worse is. The parents came back, and 2 of them got admitted to the hospital, actually. But that communication with the parents really helped us to not miss something, and knowing that they had RSV really helped me to kind of like advise those parents in a way that was more accurate.
Tell me about seasonality. You mentioned it before about viruses. One of the big things, and I know you're a tremendous advocate and you have a group, and maybe you'll tell us a lot about it, for asthma. Asthma is a common disease.
Absolutely.
And on Staten Island, inner city, dust, and you'll talk about it. Tell us how moms, dads, and the children, there's nothing more frustrating than not being able to exercise, go to gym class, being outside and taking a walk and having the cold or induced asthma. Tell us a little bit about asthma, and how as a pediatrician do you treat it or take care of it?
So asthma has different severities, and it's important for pediatricians and for parents to really have a close follow for kids with asthma. So even if I have mild-intermittent asthma, and if they're controlled, I will see an asthmatic usually every 3 to 6 months, even if they're controlled, because we want to make sure they have enough medication. We want to make sure that the symptomatology doesn't change, because asthma can be induced by different things. So you might not have any asthma symptoms in the summer because you have allergic asthma, but once ragweed season comes in, you might need preventive medication so you don't end up in the hospital or having an asthma attack, or end up not even being able to exercise. So not being able to exercise is not acceptable. So I always tell parents, we have this whole idea from asthma, like an asthmatic cannot exercise. No, that's not the idea. The idea is, as a physician, I have to make sure that I treat you well enough that you can exercise like any other kid. And that's the key. Follow-up and adequate treatment. And when needed, referral to a pulmonologist and an allergist.
Right, because the idea of people using inhalers all day long also is something
it's not acceptable, no.
Right.
That's our goal is that you don't need to use that rescue inhaler, and that you can exercise. So we do the preventive treatment and the appropriate treatment according to the severity, with the appropriate multidisciplinary team that needs to be involved, depending on what degree of asthma your child has.
It's almost not fair to have you here in a sense, because you take care of all of pediatrics, and pediatrics takes care of young people. We said infants up to 21 years of age. Takes care of every medical system. So when I sometimes have this program, and on the program we have like an endocrinologist, so we talk about diabetes, and we have a stomach doctor or a heart doctor. I'm asking you sort of everything. But as in the screening, what we sometimes see in high school, a little bit long, and even for grade school, a lot of times the schools will ask the pediatricians for evaluation of someone's heart before they go into competitive sports, particularly high school sports. So tell us a little bit about what you feel about it and how you evaluate a child for that.
So when I just did this like probably like 10 times this week only. So child going back to school, they all who are going to be involved in sports, they come with a sport form. So the main thing is to get a good family history, to do a thorough physical exam, and to really see who the child is, right? And what the risk factors are. So most kids, they have a normal blood pressure, they have a normal weight, they don't have any medical problems, and they have a normal exam, and there's no family history, there's no, they can participate in sports, right? But our job, again, as pediatricians, is to pick that one needle in the haystack, right? So we have to be well informed, and at when is a child at risk for heart disease, like for hypertrophic heart disease that happens usually during teenage years, that can put kids at risk for having an arrhythmia and sudden cardiac death, which is what we've seen, unfortunately, in athletes in high school sometimes, or even in competitive sports, in professional sports. So, these things are in family. So there's a family history of an arrhythmia, or there's a family history of a large heart as teenagers. If there's any symptomatology, if there's any abnormality on their vitals, on their blood pressure, those are things we need to address, and that you need to have evaluated by a cardiologist before you can say that this child can participate in sports.
I'm going to jump ahead now. I'm going to go into the teenage years. Do the teenagers want to come see you?
They do. They do.
Yeah.
I see 40 teenagers a week at least.
Really?
Yes.
And are they open with you about issues of sexuality and lifestyle issues?
They are, and they are because you have to provide the system for it to be there. So it is, one of the things we do. I mean, I have kids that are now 14, 15, because I've been at Rumsey for the last 15 years, that I saw them as newborns, right? So
wow.
So you need to follow them, and the families, and you start preparing the family for the idea that when they become teenagers, you have to give them a time alone to speak to them, because you have to be able to help them in any part of their lives. And that's actually New York State law, because right? That teenagers have to have their time alone to talk. And we have like an icebreaker that's called the adolescent questionnaire that we put together. Not me, the previous person, Dr. Vadi, who was our chief of ambulatory pediatrics before, did a wonderful job, and put a few questions together that address school, home, sexuality, drug use in a very non-threatening way, and they fill it out and give it to us. So usually, most of them, I would say 60% of them are usually very honest because they know that they trust that that part of it is something that we only discuss with them. And I know parents sometimes feel uncomfortable with that because they want to know everything. But I really invite them to think that that time it's really something they need to start maturing as future soon-to-be adults, and also for them to take responsibility over their lives. As pediatricians, we are there to help them kind of like not make decisions for them, just like we don't make them for parents, but to give them the best facts and that they need to make decisions that will be the best for their health. And it cannot be done if you don't have that time with them. So we do have that. They trust it. They know it's there, and they're very open to it. And I've learned so much from them just being able to, to give them that opportunity.
We're coming to the end of our half hour, but just as a parent, if you found out one of the kids that you take care of is a teenager and is starting to smoke, I mean, clearly you just described the boundaries that you wouldn't run to the mom and dad. What would you do? What would you do? And how would, if you're a parent out there and you start having the idea that they're smoking cigarettes or even drug use of some kind, what would you do? And
so I always tell parents, so the first thing parents want me to do is do a drug test.
Really?
So it's not legal for me to do a drug test on a child against their will. And I always explain to parents, plus that's not going to create a good rapport between you and the child as they become an adult either. So the idea is to let that child understand that they need to be healthy. So we also work very hard to connect kids to smoking cessation programs, to substance abuse programs that can help them kind of like be able to put that part of their lives under control. Something like marijuana. A lot of kids and adults don't think that marijuana is a problem, right? And I'm not anyone to judge if it's a problem for an adult because, marijuana is like alcohol. Not all of us are drunks, but some of us have a drink when we are in a party. But for a child, it's not, it's very dangerous because their brain is still developing, right? So I always
they develop up until
exactly 25. Yes. So I always tell kids, you're not an adult to make such decisions. Just like you cannot drink alcohol, you can, you shouldn't use these drugs. But it's just really making them aware of the effects, but also listening to why they're doing it, right? So my experience is a lot of people are self-medicating for psychiatric problems, anxiety and depression.
Because, and again, this is marvelous, and I can't wait to have you back again.
Thank you.
As I said, it's almost not fair to bring someone who's such an expert as yourself to talk about every single topic in their field. But the idea of using your pediatrician as your resource is tremendous. Whether you have any concerns about because of concerns about your child, and you're the main advocate, of course, as the parent. But always talk to your pediatrician. They're always there, and they really are marvelous healthcare providers, especially during these difficult times. So thank you again.
Thank you for inviting me.
It's been a pleasure to have you here.
Thank you.